Hello, everyone. Thank you for joining us on this episode of BAEP Talks With. It's a discussion with a person of interest who has experience living with, managing, treating, and/or supporting others with a chronic menstrual health disorder. My name is Julia Mandeville, and I am your host. Today, I am joined by Dr. Tania Whitby-Best. Did I say that right?
Tania.
Whitby-Best, yes. And we're going to be talking about sexual health today. So a little bit about Dr. Best, and then we're going to get right into the meat of the matter. So Dr. Whitby-Best graduated from the Faculty of Pure and Applied Sciences, UWI in 2000, and the Faculty of Medical Sciences, UWI in 2005. Following the completion of her internship at the Queen Elizabeth Hospital in Barbados, she joined the Department of Otolaryngology. I hope I said that right. That's ear, nose, and throat, yes?
Yes.
Good. And subsequently joined the postgraduate family medicine program, where she completed the Master of Science Family Medicine in 2012 and the Doctor of Medicine in 2014 at the UWI Cave Hill campus. She's presently resident medical officer and head of the Student Health Clinic and a part-time tutor with the Faculty of Medical Sciences, UWI Cave Hill. Dr. Whitby-Best is passionate about mental health and primary care. This interest has led to research on the topic of depression among type 2 diabetics in Barbados. She is presently the Honorary Secretary of the Caribbean College of Family Physicians and a member of the Barbados Association of Medical Practitioners CME Committee. She has also served on other professional committees such as Junior Doctors Association. Besides the practice of medicine, Dr. Whitby-Best has a keen interest in the performing arts, especially dance, and has been an active dancer and choreographer during and post her university years. Welcome, Dr. Whitby-Best. Thank you for being here.
Oh, thanks for having me.
I'm very excited about this conversation, if you can. It's really important.
Yeah, it is. It is very important, yes.
And so
overlooked sometimes.
Sometimes, yeah. We did some posts yesterday about the reason how sexual and reproductive health are usually grouped together, but sometimes we need to talk about them in their, separate capacities. And so we're going to focus a lot on the sexual health aspect today. But before we jump right into that, let's talk about family medicine. What is it? What makes it unique?
Well, it's a medical specialty which has postgraduate training. And basically, you provide primary care for the entire lifespan of a patient in a community setting. And if you look at some of the definitions, the American Academy of Family Physicians state that unlike things like pediatrics, where you mostly deal with children, internal medicine, where you mostly deal with adults, family medicine encompasses all age, sexes, different disease entities. And it's pretty unique because you get an opportunity to have an impact on the health of an individual throughout the whole life cycle, the whole entire lifetime. Mm-hmm. The training in family medicine encompasses so many things: management, public health issues, clinical management of non-communicable diseases, communicable diseases, medical ethics, medical legal issues, child health, mental health, and also you gain very good community counseling and communication skills. So that's what makes it pretty unique.
So it sounds like kind of the medical aspect of what we do in public health, where we look at the wide berth of, everything that's happening in society, and kind of we develop initiatives or write policies for, the community, whereas you have the aspect of the medical intervention for people throughout any point of their life. That's interesting. So what made you decide that this is what you wanted to specialize in?
Well, it wasn't my original choice. I did have different goals. Before going into medical school, I thought I wanted to be an oncologist, and that quickly went away because I realized I prefer to focus on more preventative care. I did spend 3 years doing ear, nose, and throat surgery, which I enjoyed thoroughly. It was the one surgical field I thoroughly enjoyed, but I wasn't in a postgraduate program. So I started thinking, okay, what could I do? And I like to tell persons, there are some people who say you should have a goal, set that goal, go for that goal. But sometimes in life, different paths open and different things happen that gear you towards a different goal that might actually be a better goal for you. So I'm one of those persons who think like that. I always think of, okay, if this is not working out the way I want, what else can I do? Or what else would I like to do? And then I thought of family medicine. I applied and got in, and I very happy with that decision. You know, I can focus on preventative care, helping behavior change, managing a wider subset of issues. I see family physicians like the center. When you ever play netball?
Yeah.
It
was the center.
You do the most work.
Yes.
And you are able to go everywhere to help the team.
Mm-hmm.
So I see family physicians as that part where you can be that center for a patient, a client, and be able to gear them to the different health aspects of medical health and care that they need. Be that central part for them.
Yeah, I am seeing so many commonalities between family medicine and public health, because in public health we focus a lot on linkage to care, so we can as that vehicle to direct persons to different resources within the that could better address their needs. So yeah, and yes, I was the center. I couldn't shoot, but I was able to get the ball to whoever needed it.
Yes.
So we're going to focus a lot on, and thank you for that, this conversation is going to focus a lot on sexual health. And as I said before, with BAEP, we do have a strong focus on reproductive health and reproductive health care access. But you really can't have one without addressing the other. And so I thought this was a great time to start that discussion as well. But I guess a lot of people might not know if there's a distinction and why there is. So what is the difference between sexual health and reproductive health, and why, in your opinion, or maybe why is it best practice to have that distinction?
Well, sexual health, as defined by WHO, is a state of mental, physical, emotional, and social well-being that's related to your sexuality. And you don't want to merely look at the absence of disease or dysfunction or infirmity associated with sexual health. You want to have a positive and respectful approach to sexuality. Reproductive health state is that of a physical, mental, social well-being and all matters related to reproductive system at all stages in life. That people are able to have a satisfying, safe sex life that will lead to, you know, being able to reproduce, the capability to reproduce, the freedom to choose when, and fun. And that's a pet peeve of mine. When it comes to persons discussing reproductive health. You know, in the Caribbean, persons always look, you're married for this amount of time, or even if you're not married, you reach a certain age, when you're going to have that child, or when you're going to have the next child, and policing uterus, person's uterus. But be careful, because sometimes you don't know if that person may be having difficulties or challenges in reproducing, and you may actually, in doing that, you know, affect their mental health even more, because we know mental health issues are less linked to infertility issues and so on. So I just think I'll just put that out there, that in talking about sexual health, reproductive health, especially, that we try to be sensitive to what someone's experience might be when we're discussing these issues.
For us to talk about sexual health, we cannot, it would be remiss of us to avoid talking about STIs, which were formerly called STDs. I think in some settings they're called STDs too. So what are they, and then what's the difference between STI and STD, if they're supposed to be used interchangeably?
Well, persons do use them interchangeably, but STIs refers to sexually transmitted infections. STDs refer to sexually transmitted diseases. And infections are caused by bacteria, viruses, parasites, and so on, and that can lead, infection can lead to disease, right? Now, what was found is that the term infection is less discriminating and more likely to encourage persons to get tested, especially if they don't have any signs or symptoms of infection or disease. So it was thought to instead say sexually transmitted infections, to try and discriminate, to decrease that discrimination, so persons are more likely to want to get tested. I'll give an example. So HPV, human papilloma virus, we know is highly linked to cervical cancer. But someone having human papillomavirus or a female having human papillomavirus does not necessarily mean she will have cervical cancer. Okay, so that is one example. And then the other would be chlamydia and gonorrhea. Infection can lead to pelvic inflammatory disease, but not everyone with chlamydia or gonorrhea infection do have pelvic inflammatory disease.
All right, thank you for that, Dr. Whitby-Best. So what is safe sex? We hear about the transmission of STIs, the development of STDs, and that if you're gonna have sex, have safe sex. But what is safe sex?
Well, safe sex really is abstinence, because sex in itself is not 100% safe. So I prefer to say the term safer sex.
Okay, safer sex, yes.
Right. Safer sex. And it's really having sex with a lower risk of acquiring sexually transmitted infections. How you can achieve that. And one way is trying to, there are things you can do to protect yourself before having sex. Limiting the number of partners you would have, knowing the history of your partners, their sexual history, if they have had any infections or treated for any infections, do they have any of the diseases, knowing that it would be a good idea to test it before sex together. I do encourage that every time you get a new partner, go together and get tested. So you know what's happening. There might be something that can be treated to make the experience more pleasurable for you, with less worry. Avoid sex under the influence, such as the use of illegal drugs and alcohol, because then you lose inhibition, you're more succumb to being exploited or abused. And vaccination. Now, human papillomavirus, there's a vaccination which has been proven to be safe and effective in decreasing the incidence of cervical cancer. And if you look at studies from Australia, where it has been done pretty widespread, they're almost at a point of almost eradicating cervical cancer in their population. And also hepatitis B, we're already doing that in the Caribbean and throughout the world. From infancy, you're now vaccinated against hepatitis B. So those numbers are decreasing, and hepatitis B can lead to liver failure and cancer and so on. So those are one way in terms of preparing before having sex, and then protecting yourself during the act itself, using condoms, dental dams. If in the case of manual manipulation, you might want to use gloves if you don't know the status of the other person. So what I think constitute what safer sex is.
But the only quote unquote safe sex is abstinence.
Because yes, it's not 100%, but you can put things in place to make it safer.
And then I'm also wondering if one of the reasons why sexual reproductive health are usually presented together is that if someone possibly contracts an infection, it could impact their reproductive organs and then their reproductive health.
Yes, so, like as we mentioned, PID, pelvic inflammatory disease before.
Right, okay. And so with all that being said, what are some of the common misconceptions or myths students might approach you about when they come to your clinic, or maybe even the wider population, because you've had experience in other clinics, in other settings, about sex and STIs?
Right, because I did work in quite a few years in the polyclinic before going in at UWI, and in general, there are quite a few misconceptions. I'll mention a few. One with pregnancy prevention. In taking the history, sometimes, you'll ask the person is sexually active. They're sexually active, but they're not using any form of contraception at all. Then you ask about what are their thoughts or their concern about getting pregnant, and if they would want to be pregnant. Now, most times it's usually no. Want an unplanned pregnancy, but then you're saying, well, in terms of how would you then think you can avoid an unplanned pregnancy? Sometimes persons will talk about withdrawal method. I'm still kind of shocked that persons are not aware that, yes, there's pre-ejaculatory fluid that can also have sperm, which still puts you at risk for pregnancy. And I like to say that if your reproductive system, reproductive organs are working normal, and this is for heterosexual couples, and you're having regular intercourse, most persons will get pregnant within a year of that. So if you don't want an unwanted pregnancy, then you need to have some factors, use some form of contraception. And then the misconceptions about the various types. Recently, my colleagues and I in family medicine have been trying to do a lot of push intrauterine contraceptive device, IUCDs, DT, Marina, and so on. Most effective, safe, long-term for someone who know they don't want to get pregnant for now. But then when you try to speak to patients or clients about it, oh, that's gonna make you smell. I hear it's gonna make you smell. I hear that the man is gonna feel it because there's a string left out to the cervix, and so on. And I remember even seeing a program on Instagram where some men were talking about their girl can't get that. Because yes, I was quite surprised their girl can't get that because of what they believe it means for them, that they will feel it, or you know, they don't want their woman to get that don't seem natural. You know, it's surprising still, the thoughts about IUCDs, right? One of the most effective, safe contraceptives out there. But so that's one that we're still working with.
But I'm also, not to cross you, but I'm just also intrigued by the notion that, you know, it's not necessarily that the woman, the female partner might not want it for her, but the man not want it. About how the male partner would feel, and I have some thoughts about that. But we'll leave it there because it's okay. I'll leave it there.
It's a little shocking to me too, right? Yes. And I think some of it is just not understanding, a lack of the knowledge, where you know they probably don't understand what, and I guess this is another whole topic altogether about contraception and the fact that it's so female based.
Yes.
And so on. Other misconceptions, some persons still do not refer to anal and oral sex as sex.
Yeah.
Whether they're homosexual, heterosexual, bisexual. It's not often, but a few, you still come across a few persons. So when taking sexual histories, always make sure, you know, I ask specifically if you're engaged in any of these activities. Some people will not report it on their own because they might not consider it sex and not think their risk is still there.
The only thing vaginal penetration is sex.
Yes. Okay. Some people still think that if you have STIs, you'll be symptomatic.
Right.
And that's one of the things we push with, and you mentioned UWI HARP in terms of sexual education and so on, that quite a few STIs are asymptomatic. That's why we push the regular screening. You have a new partner to get screened and so on. And also with the same, not constituting certain things as sex and so on, how you get things like HPV and HSV, human herpes simplex virus, doesn't have to have sexual intercourse. It can be just close contact of skin, you know, in rubbing and so on. And if there's an obvious herpes lesion or so on, that's also another way of transmission. And the views on these viruses. So a lot of education still needs to be done about that. And another thing I call this, don't judge a book by the cover. Some persons believe if they're diagnosed with an STI, that their partner cheated. And that might not necessarily be so. As we said, some things may not have symptoms, and the partner may not even have known that they had this STI. And that's why we encourage the regular testing, you know.
Right. And so I guess we need to talk about how we can stop the spread of the misconceptions and the misinformation. And kudos to UWI HARP, kudos to Monique and her team for the work that they're doing at UWI and in the wider community. But then talking about the wider community, how can we as just general citizens in the community work to stop this spread of misinformation and the misconceptions about sex?
So, well, we need to incorporate the community in the whole process and in the whole education, because behavior is learned. And behavior and practices, cultural practices and norms are going to be passed down. And you have to change it at each level, right? So, and as I mentioned in misconceptions, a lot of persons will say, well, I was told this by this person or that person and so on. And so it has to be at the community level. It can't just be trying to, and then trying to target the different groups within the community. I was reviewing the American College of Health Associations data on health promotion and clinical care. And they mentioned talking about a holistic approach to doing sexual health promotion, looking at different aspects, mental health, which tend to forget that sometimes, the association with sexual dysfunction, healthy communication to maintain good, healthy, and intimate relationships that tend to sexual health. They advise not to too focus on STIs,
Right.
and unwanted pregnancies, because, and I remember attending a lecture given by someone who was doing some research on the views Barbadian parents on HPV vaccine. And one of the main things was associated HPV vaccine with your child is going to have sex at some point.
Early sexual
And then parents think about, oh, they're going to get pregnant on me or something at a young age. So try to steer away too much from that in doing sexual health and looking at the realities of sexual experiencing and trying to reduce stigma and shame associated with it. And as healthcare providers, you know, in our sexual histories, we should try to do that for everyone. Try to encourage questioning about sexual function and their personal views, religious views about sex and so on. And I want to mention here consideration for special groups, transgender, persons with disabilities, the elderly. We tend to forget them sometimes when we're talking about, especially elderly.
Yeah, we tend to not think about
elderly
it.
People are not doing anything, right?
We know that.
Yeah, but remember, they're too at risk for sexually transmitted infections, and I've seen elderly persons who acquire HIV and so on. They're less likely to use condoms because they're not worried about getting pregnant, you know? So we have to incorporate at every level in our health promotion for everyone. So again, kudos to UWI HARP, doing an excellent job on campus, and hopefully, you know, and also, well, in the wider community, the polyclinics, Ministry of Health and Wellness, they've been putting out data on the STI testing and so on, what's happening, the trends and so on, and trying to encourage change in behavior.
I've seen it, yeah, because that's like you rightly said, it needs to start in the community. And so with UWI HARP, they're starting with the UWI community, and hopefully, you know, those individuals that are getting that education are going back into the community and educating peers. Yeah.
One thing, because they do have a peer mentorship program where they actually train persons in these skills and train, you know, so then they too can become empowered as student leaders and take that into the community. To change the mindset. One thing I just want to stress that in doing all of this, we have to remember the confidentiality issue. Yes, we want to be more open in the discussion, but persons are still very shy and, you know, not willing to broadcast their sexual experiences and so on. And to be mindful of that. We have to be mindful that some persons may have been exposed to trauma. Their first experience might have been traumatic.
Yeah.
And even as clinicians and so on, when we have someone we have to do some form of pelvic examination on or so on, to be mindful and to ask in terms of have they been exposed in terms of how they feel about the examination. I tend to try to explain, if you're going to have a pap smear, you know, try to explain as best as possible what it entails. And one or two persons are not very tolerant, right? And you have to be mindful of that, that if it's not, they're not very tolerant, then, you know, you don't push.
Right.
You do another time or something. Yeah. Because you don't know if it's due to some form of traumatic experience that they may have had. Right. Also in terms of maintaining the confidentiality, you know, no one should feel stigmatized or scared to come into a place of a healthcare facility and express these views. You know, I've had patients say to me, but I thought you to be shocked or surprised by what I tell you. I'm not. I'm not. I'm not at all, right? That's your experience. That's what you know, and it's important for me to get that information, and in a way that you feel no way discriminated in any way of giving the information, because it's very important to the outcome of how, moving forward, we're going to help and assist you and manage the problem that you have, right? So I am not fazed by or I try not to be, but encourage persons to be open and know that that information is going to stay here.
Mm-hmm. Yeah, you remind me of, we did this BAEP talks with Jasmine, and she made mention of that, recognizing that, especially when it comes to patients that might have endometriosis or some other type of pelvic condition that might cause physical trauma, recognizing that and working with the patient to reach, a consensus as to how best to move forward for both of them. Right. As patient and practitioner. But you also reminded me of something that in my current job I'm learning a lot more about, which are ACEs, adverse childhood experiences, and the trauma that can come along with the fact that you could be exposed to a particular ACE, and you might not even necessarily be aware of it. So some could be very apparent, and some could be so subtle that you're carrying around this trauma and you just have no way of quite identifying it, but it is enveloped in your daily life. And it's important for your practitioners to recognize that trauma creates a response, and to work with their potential clients or patients to, again, come to the best point where you can move forward together. So thank you for having the space to allow for that.